see on the left hand is a picture of an instrument table. That's just the routine setup for labor and delivery. And on the right is a picture of a labor bed. So what's awesome about these labor beds, especially when you have a patient with an epidural, you can get them into various positions to simulate that natural labor and the natural movement that moms do if they don't have an epidural. Okay, so now we're ready for the second stage of labor. So second stage is from complete dilation and effacement, so 10 centimeters, to when the baby is born. So it begins with 10 centimeters and complete effacement. At 100%, it's the pushing stage, and it ends with the infant birth. So you can see here the progression of birth in the A, B, C, and D in the pictures here. The duration of the second stage of labor for somebody who's never had a baby, so a primip or nullip, whichever one you'd like to call it, is 2 hours without regional anesthesia, and 3 hours with regional anesthesia, and that's usually referring to an epidural. The average time is 50 to 60 minutes. So if it's your first baby, the normal time is 2 hours of pushing. If you do not have an epidural, if you do have an epidural, up to 3 hours, with the average being anywhere between 50 and 60 minutes. If you're a multip and have had babies before, 1 hour without an epidural or 2 hours with an epidural is considered normal, and 20 to 30 minutes is the average. The second stage of labor has 2 phases. It's the latent phase. This is the time when the patient's relatively calm, and this has passive descent of the baby through the birth canal. So essentially the contractions are doing all the hard work and pushing the baby through the pelvis and birth canal. This is also, if a patient has an epidural, it's called laboring down. You still change their positions frequently at a minimum of every 30 minutes. And it's best practice to wait until the patient feels the urge to push, if at all possible with an epidural. It depends on how heavy the anesthesia is with the epidural. Some patients literally cannot move their toe. The perfect epidural is when a patient says. So the second phase, so the active phase of the second stage of labor. Second stage of labor has 2 phases. That second phase is the active phase. So this is the time when the patient is actually pushing and feels the urge to bear down. Ferguson's reflex is when the baby gets to approximately a fetal station of +1 and it's in an anterior position, there's a surge of oxytocin that is released, and that further increases the urge to push. So basically, as the baby descends down into the pelvis at about a +1 station, the Ferguson's reflex is a surge of oxytocin that furthers her urge to push even harder, which is a good thing at this point. During this stage, the active stage, as opposed to the latent stage where, patient's very calm, women can be very, very vocal in this stage. It can be scary if there are children in the room. Sometimes the patient's partner has never seen her in this much pain, and they are very scared and just kind of at a loss for what to do to support them. So what we should do is encourage the patient to listen to her body. So if she feels the urge to push, we should encourage her to just go with that urge to push and just push until as she feels it. Now, pushing prior to the cervix being a complete dilation can cause the cervix to swell and lacerations to the cervix. I think your book refers to pushing before 8 centimeters or so. So if they feel an urge to push, a strong urge to push, or the baby's coming down very rapidly, but they're not completely dilated, sometimes that can cause edema in the cervix and lacerations, and it can actually slow labor down. On page 455 in your book, there is box 1910, and it has nursing care in the second stage of labor, so you should be familiar with that also. The next is to prepare for birth. lists the positions as supine, semi-recumbent, or lithotomy positions are still widely used in Western societies despite evidence that an upright position shortens labor. So for maternal position, we should encourage frequent position changes. Upright positions are beneficial to both the mom and the baby. These positions include walking, standing, kneeling, or squatting. This position straightens the birth canal and improves alignment of the fetus through the pelvis. The application of gravity facilitates fetal descent when the mom is standing up. It actually, in this position, enlarges the pelvic diameters. We talked about contractions being more efficient, meaning they're stronger, and this enhances the bearing down efforts. With the bearing down efforts, we know we should avoid the Valsalva maneuver, and that's when a patient takes that big deep breath and pushes as hard as they can to the count of 10. That's, here in the United States, what we're accustomed to seeing when you watch on TV with the birthing channel and the different TV shows that are on. That's what you see. But what we should encourage is an open glottis pushing, and that's when the patient can be vocal. So when they're pushing down, they also make noises, and that is okay. The active pushing stage is the most physiologically stressful part of labor for the mom. And as the baby is coming out, usually moms are encouraged just to pant as the head crowns. What you want to do is have a controlled delivery. You don't want mom pushing so hard that she causes lacerations that may be prevented when you have a controlled birth. It's also, we talked about fetal heart rate and patterns already. It's also important to support the father or the partner. If they have been at the bedside for hours and hours, they may feel like they need to be relieved. So maybe, telling them if they smoke to go smoke, if they need to go to the cafeteria to get some caffeine, some coffee, or something to eat, that's important too. Supplies, instruments, and equipment. You'll know that somebody that's working in labor and delivery, if it's a hospital that has OB techs or surgical techs, or you could be setting up your own room, but you get the birthing table and the instruments ready, and you also bring in the infant warmer. Some hospitals have this equipment in every room, and some hospitals have to move this equipment from room to room. Birth can occur in a delivery room or a birthing room. A delivery room is where you labor and deliver in the same room. A birthing room is where you would labor in one room and be transferred to another room for the delivery. The mechanisms of a vertex birth include birth of the head, birth of the shoulders, and birth of the body and extremities. Usually we see birth here in the western part of the world in the United States in the lithotomy position. Crowning is when the widest part of the head, the biparietal diameter, distends the vulva just before birth. An episiotomy is an incision of the perineum to enlarge the vaginal outlet, and we're going to talk about the different types of episiotomies and the benefits and risks here in just a second. The Röntgen maneuver is a maneuver that you see a lot of doctors use, especially older doctors, where they're placing, you can see in the pictures here at the top, they're placing pressure on the rectum, coccyx, and fetal head to control the birth of the head from it being too rapid. So you can see they're kind of pushing up on the rectum, flattening that rectum and the coccyx bones. And then with the bottom hand, their left hand, and the right hand is on top, and they apply just a little bit of counter pressure so the head doesn't pop out all at once. It's a very controlled, slow delivery that allows for the natural stretching of the perineum to hopefully prevent episiotomies and any type of lacerations. And there was, a little bit more in the book on that maneuver. Nuchal cord is when the umbilical cord encircles the neck. at delivery, and so what the provider, the physician or nurse midwife will do, if it's loose enough, they'll just reach down and slip the cord over the neck and finish delivering the baby, the shoulders, and the rest of the baby. If it's super tight and they can't reduce it, what we call reduce it is when they slip it over the head, they'll put clamps on it and cut it right then. That way it doesn't get tighter as the baby's delivered. Talk about use of fundal pressure. Fundal pressure is gentle application of pressure against the fundus of the uterus. So remember, the fundus is the top part of the uterus. So fundal pressure is when you would push down on the top part of the uterus. It's contraindicated during a vaginal birth. Way back, it used to be used for when patients were put to sleep, and at one time thought it was beneficial if you had a shoulder dystocia to, from above to kind of help push the baby out. But what we find is it further impacts the baby. When I say impacts, it gets it stuck even further in there. So just know that fundal pressure is contraindicated during a vaginal birth, and it's only used during a C-section. So if you've seen a C-section in clinicals yet, the assistant helping the physician deliver the baby applies. It is not gentle. It's a lot of fundal pressure in C-sections, and that's where they're pushing on the upper part of the mom's uterus, on the fundus below her xiphoid process, and they're actually pushing the baby out the uterine incision. That should not be done vaginally. Immediate care of the infant. You place the baby skin to skin. Do an APGAR score at 1 and 5 minutes. You also want to maintain the airway and prevent cold stress. So I'm not too sure if that part of my notes scanned in. So immediate care of the infant, place the infant skin to skin. APGAR scores at 1 and 5 minutes. Maintain the airway and prevent cold stress.